Hi everyone, welcome to the Webinar Wednesday. I'm your host Nimish, and I just want to thank everyone for joining us today. As you know, this month is Women's Health Month, and today's speaker, Dr. Benjamin Dillon, is going to go over several topics that we've put forward here to give you a bit more information of how to become healthy. A little bit of information about Dr. Dillon. He's board certified by the American Board of Urology, urology and female pelvic medicine, and reconstructive surgery. His interests include incontinence in male and female, pelvic organ prolapse, voiding dysfunction, urogenic bladder, pelvic floor reconstruction, BPH, and urodynamics. He recently just celebrated his 6-year anniversary at Kelsey-Seybold, and he practices at the Breathitt Main campus, the Fort Bend Diagnostic Center, and the Spring Medical and Diagnostic Center as well. Just a reminder, we will be taking questions at the end, so please feel free to type them in your question box, and we'll do our best to address it at the conclusion of Dr. Dillon's presentation. With that, I will hand it over to Dr. Dillon to begin his talk.
Okay, thank you, Nimish. And thank you all for signing on and tuning in. Obviously, there's a lot we could talk about for women's health, and we just try to narrow it down to 3 very common topics that I see daily in my practice. Probably the most common one being urinary tract infections, and moving on to prolapse, and then lastly incontinence. Again, these are very broad sweeping topics. Just going to glance over the surface of them, and certainly any questions that you have, feel free to ask them at the end, and we can dive into them a little further, time permitting. So urinary tract infections, what are they? Urinary tract infection obviously is any infection of any part of the urinary system, with the urinary system being the kidneys, the ureters. Those are the tubes that drain the kidneys down into the bladder, and then the urethra, which is the tube that we urinate out of. And both men and women do have urethras. Most infections typically involve the lower urinary tract, which is the bladder and the urethra. It's a big misconception when patients come and see me that their back hurts, which means they might have a urinary tract infection. So that can be true, but typically when a patient has back pain associated with a urinary tract infection, it's not that their kidneys are involved. It could be for something else. If they have kidney involvement of the urinary tract infection, they're usually quite sick. Usually they have cycling fevers, and that's often a sign of pyelonephritis or infection of the kidney. But routine urinary tract infection that involves just the bladder and the urethra, usually not associated with back pain, and the back pain is due to something else. 20% of women in the U.S. will develop a urinary tract infection, and 20% of those women will have a recurrence. So we need to, I'm a little stickler for terminology and using the proper phrases, so we need to distinguish between or differentiate between a recurrent urinary tract infections and frequent urinary tract infections. So a recurrent infection is an infection that comes back, meaning you have the same bacteria. And by the time patients reach me for their urinary tract infections, they've already usually been seen by our frontline or PCPs, FM or IM, and they've had some sort of urine study, be it urinalysis or urine culture. Once they hit me, my team, which is my nurse and my 2 PAs, we typically try to get urine cultures. That's where you grow urine out on a petri dish, and you actually see what bacteria it is. And then we take it one step further and look at the sensitivities, meaning what antibiotic would be appropriate to treat that bacteria. So recurrent infection is when a woman keeps on getting the same bug, that such as, they may get E. coli, they may get Klebsiella, they may get Enterococcus. That is different from frequent infections where women get different bacteria. They may get Klebsiella one time, they may get E. coli another, or they may have E. coli switch between Enterococcus and then get Klebsiella again. That is not a recurrent. Those are frequent infections. As women get older, they lose some hormone in the vaginal area, and they are predisposed to urinary tract infections. Typically, we allow women 3 to 4 infections per year before we deem them recurrent or say that this is a problem. Another thing that I see quite a lot in my practice is we call asymptomatic bacteriuria. That's when women have bacteria that's been picked up in their urine. Usually it's a strain that for some people would be an infection, but if they don't have symptoms, we don't treat it. There's a lot of emerging data that shows that some bacteria in the urinary tract is protective. That's similar to what we see in the bowel, where everybody has bacteria in the bowel, and sometimes you don't want to necessarily destroy that flora. It could be protective against further strains or different types of bacteria that may infect women. Symptoms, this is the big one, and again, these are can be specific to a urinary tract infection, but they're not necessarily sensitive. So a strong persistent urge to urinate, burning when patient urinates, small frequent amounts of urine every time they void, urine that appears cloudy, urine that is blood tinged, or strong smelling urine. So I need to qualify some of these. Any one of these can be associated with an infection, but again, they're not all classic presentations of infection. I could probably debunk each and every point why they're not associated with an infection, but the big ones that I get is my urine smells. Well, you know, urine is excrement. Urine is, you know, breakdown and toxins. So of course it's going to smell. Obviously, foods, vitamins, concentration of urine is going to breed different smells. So just because you have a strong smelling urine or even foul smelling urine doesn't necessarily mean that's an infection. Same thing with cloudy urine. You know, if you're not drinking on these sweltering summer days in Houston, your urine may be a little concentrated, could be cloudy. But again, a lot of times we use these as screening modalities to key us in that maybe a woman is having infection. But again, these are symptoms. They are not sensitive and specific, but they are associated with urinary tract infections. What are the treatments? Well, if a woman, again, by the time they reach me, we've had cultures. So cultures will tell us what bug they have and what bacteria they are sensitive to. So in that case, we give them a round of antibiotics. We base our antibiotics on cultures, and then also patients' kidney function, their allergies, but we generally try to target what the infection is. Again, if a patient is not symptomatic and they have an infection, we may choose not to treat them and wait until they have symptoms of an infection. A lot of people ask me about home remedies for urinary tract infections. Sure, they could work. I don't discount anything. The best thing to do is when you have the onset of what you think might be an infection, flush yourself, drink plenty of water, help dilute and flush out this bacteria. Avoid bladder irritants, anything with caffeine, artificial sweeteners, alcohol, citrus. Those may all irritate or exacerbate underlying symptoms. A lot of conflicting information on cranberry juice. Cranberry juice in and of itself is not going to reduce urinary tract infections. The active ingredient is proanthocyanidin in cranberry, and what that does is actually binds to what we call the pili, which is the arms of the bacteria which help them climb into and ascend the urinary tract. So the amount of cranberry juice you need to drink to prevent an infection is enough to quench a thirst of an elephant. So I don't think patients are going to reap the benefits from just drinking cranberry. There are a lot of cranberry supplements on the market. I just caution patients to know what they're taking. I use one in particular. If you want that, you can contact me. But this has 36 micrograms of PACs, which have been clinically shown to help reduce infections. I think we touched on this earlier, chronic versus recurrent urinary tract infections. Multiple UTIs in a single year are chronic. They are recurrent if it is the same bug. We can modify our treatments based on this. So for somebody who does have recurrent infections or infections related to intercourse, we can put them on a low-dose antibiotic once a day. Sometimes giving some vaginal estrogen cream is enough to change the pH of the vagina and make it harder for bacteria to stick and ascend into the bladder. A lot of time, and then again, we have to look at a little more complex things. Is there an anatomic abnormality? Do they have prolapse, which we'll get into shortly? So prolapse, what are the causes, what are the symptoms, and what are the treatment options? This and incontinence come hand in hand in my practice. I see this probably secondary to infections the most. So prolapse is, prolapse is a hernia. It's a hernia of any part of the vaginal wall. So the vagina has three parts. There's the roof, which is the bladder, the floor, which is the uterus, and then, or the rectum, then there's the apex, I'm not sure if this, which is right here where the uterus sits or used to sit in the case of a post-hysterectomy patient. You can see right here the bladder has come down from its normal anatomic position, and the rectum has slid down as well. And you can see small bowel right behind here. So again, typically we talk about prolapse in three different phases. So this is the normal anatomy of a woman, and this is a cystocele. Cystocele is when the bladder has dropped or herniated into the vaginal canal. A rectocele, again, normal anatomy on your left, and on the right, a pooch or a herniation of the rectal wall into the vaginal canal. So just to make it clear, a patient is not seeing their bladder, they're not seeing the rectum. They're seeing the wall of their vagina, which is being pushed forward or pushed out by the organ which is prolapsing. And then the last thing that we see is an enterocele. So an enterocele is almost exclusively seen in women who have had their uterus removed. So the uterus is right here, and the uterus is nice because it's a great space-occupying organ. And when you remove the uterus, you can see that it clears this space up here for small bowel to slip down, and you can have a herniation of this sac down into the vaginal canal, and that will often be a bulge that presents as well. A patient typically can't identify themselves which part of the vaginal wall is prolapsing, be it the bladder, the rectum, or the vagina, or the apex. Sometimes it's very difficult for us to tell in the office, even with speculum. A lot of times you don't get the full idea until you put them up in stirrups under anesthesia, which leads us to some risk factors and then treatments. So obviously the biggest risk factor is vaginal childbirth. Large weight babies, actually 96% of the time, it's usually the first baby that does the majority of the damage. Having a C-section is somewhat protective, but don't forget a woman still carries the fetus in their pelvis for 10 months. So that is a big risk factor as well. Menopause can cause pelvic floor muscle deterioration and drop in hormone levels. Family history is a big one, and certain races and cultures are more likely to have prolapse as well. Then chronic constipation, chronic cough can be a big one as well. Constantly increasing that intra-abdominal pressure puts weakness on the vaginal walls and can cause herniation of different organs. Symptoms, a lot of times it's painless, but women will feel a pressure or fullness in the vaginal region or rectum. Sometimes you can get some lower back pain, or women report sensation or gripping in the vaginal region like something is falling out. It can be associated with incontinence, and it can be associated with chronic constipation. Why is it important? And this is the biggest one. So just having a prolapse doesn't mean you need to have it fixed. But a lot of times women develop an avoidant personality. So they'll avoid sexual function, they'll avoid activities that they like doing, such as gardening, dancing, exercise, and then self-image. That's probably the biggest one I get in my practice, and the one that I'm most sensitive to, is women become very avoidant of their partners. They feel conscious, self-conscious about it. They try to avoid intercourse, which becomes a slippery slope when you reach the age of prolapse. If you start to avoid intercourse, you may never get that back between a patient and their spouse. And it's really important to address that in the office and try to maintain sexual function as much as a patient wants to in their relationship. Treatment options. So, even though I'm a surgeon, I feel as if surgery is typically a last option for a patient. We try conservative management. If a patient is just curious about it and they have some symptoms, we talk about observation. I'll see them back at 3 months or 6 months and re-examine them and see if the prolapse has gotten bigger. We like it to get no bigger than a stage 2, sometimes a stage 3 before surgery, but the bigger and that's on a 4-stage scale. The bigger the prolapse, the harder it is to fix, and more likely they are to have a recurrence. So some non-surgical options are Kegel or pelvic floor exercises. We have an excellent pelvic floor physical therapist that we're contracted with who does wonders for our patients. Bladder training, and then pessary. Pessary is a rubber device that is patient is measured for and inserted into the vagina. My PAs fit them, or gynecologists fit them, and a lot of times it's a great way for a patient to avoid or even put off a surgery until they're ready. Sometimes a patient can take it out and put it back in on their own and clean it. Sometimes they need to come to the office. And a lot of this depends on how comfortable a patient is with that. And then we get into surgical approaches. So I typically do most of mine through a vaginal approach. Technically, it's a little difficult to explain and understand. That's almost for a separate webinar. But it's not very painful. My patients typically stay in the hospital for a night. They're up and about the next day. The recovery in total is about 4 to 6 weeks, and that's just to let the healing occur. And the things that I tell my patients that I focus on is I look to maintain adequate vaginal width and vaginal length so that intercourse is possible. We try to get them symptomatically improved, and as far as pressure and pain and bulge, and then also try to key in on incontinence and improvement in bowel function. There are some people that do laparoscopic or robotic approaches. That's typically not what I do. If a patient needs that, I have several colleagues around the city that we will refer out to, but that's pretty rare. And a lot of the times I will do surgeries in combination with our GYNs here at Kelsey. Well, they'll do the uterus or take out the uterus if need be. Then I'll do the reconstruction. And sometimes I even fix patients with their uterus intact. We can do what's called a hysteropexy, where we just support the uterus and anchor the top, because as I said, that is sometimes a nice space occupying organ that we sometimes want to preserve to prevent future prolapses. There's an abdominal approach. It's pretty outdated, particularly advent of laparoscopic and robotic approaches. Again, longer recovery time, longer hospital stay, more pain, increase in blood loss. So typically that is not something that we do. Prevention, so these are the big ones. Weight gain, very difficult as women approach menopause. Typically their weight gain is in the truncal area around their belly. Very, very common, and there's not much a woman can do about that. Smoking, we all know the detriments of smoking. It weakens tissue, weakens collagen. Excessive lifting or squatting, a lot of times patients will come into my office and say, I was gardening and I bent down, I felt something bulge. Certainly you want to teach them adequate lifting and squatting techniques to try to prevent prolapse. Constipation, we talked about, is a big one. Vaginal delivery and excessive coughing. And lastly, I know I'm going through quickly, but time is tight. I want to get through everything, is incontinence. Incontinence is a multi-billion-dollar industry here in the United States. It roughly affects about 25 million Americans and occur in both men and women. And what is incontinence is the involuntary leakage of urine, the inability to hold urine in the bladder, and basically the lack of being able to control urine at a socially acceptable time. There are two forms of incontinence. There's stress incontinence, which is leakage with cough, laugh, sneeze, and exertion. Then there's urge incontinence, which is typically called overactive bladder. You have the sensation to go and you can't control it, and you have an accident. And then there's a third type, which is a combination of 1 and 2. That's called mixed incontinence, and that's where you actually have both stress and urge incontinence present. Stress incontinence, this is typically an anatomical issue. It's a weakness in the pelvic floor or a weakness in the urethral sphincter. And again, that's leakage of urine with cough, laugh, sneeze, exercise. Urge incontinence, we mentioned this earlier, overactive bladder, and it can be OAB wet or OAB dry. OAB dry is just strong urgency and frequency of urination, whereas urge incontinence or OAB wet is actually the urge, you can't control it, and you leak. Typically, that's divided into two other categories. There's idiopathic, which is there's no reason for urgent incontinence. In the majority of our patients, that's what it is. Vis-a-vis neurogenic, where a patient has an underlying neurologic problem, such as multiple sclerosis, Parkinson's, history of stroke. All those will increase and are likely presentations for urgent incontinence. When to talk to your doctor about it, that's the big one. Again, for a lot of cultures and generations, women don't like to talk about it. But for me, anytime a patient is bothered by it, is time to talk to a doctor. It is more common as women age, and I think it's our job and our duty to our patients to try to prevent them from wearing pads and being shy and keeping this hidden. It is not normal regardless of your age. God did not create us to have a shelf life of continence. At some point, you need to treat this. And again, it's common, but it's not part of the normal age process. Again, causes, we had talked about this: age, past pregnancy, weight, genetics, and hormone status. Treatments for stress incontinence, again, lifestyle changes, medications. There are some pessaries that can help with incontinence, and surgery. Some myths: urinary incontinence is irreversible. It is a myth that we can talk to your doctors about improving incontinence to improve your quality of life. As I mentioned, incontinence is a tremendous inconvenience and can be a large cost burden for a lot of patients. So again, we want to try to address this as early as possible. So for treatment options, non-surgical, again, pelvic floor physical therapy is a great one for women with mild to moderate stress incontinence. Use of pharmacologic agents for urgent incontinence, behavioral therapy, limiting bladder irritants, caffeine, artificial sweeteners, alcohol, increased water consumption. We have neuromodulation, which is ways to stimulate the nerves. We have two modalities of doing that. One is electric acupuncture, which is done in the office. One is an implantable sort of pacemaker for the bladder. We have in-office procedures for stress incontinence, injectable agents in the urethra, and then we have surgical treatments for stress incontinence, which is the last line. And there are slings, and we have two ways that we can do slings. One is with mesh or synthetic sling, and one is with your own tissue, and that kind of goes into a whole other discussion, argument, debate, whichever way you want to phrase it. So that's, I know, is quick, but I think we have some time for some questions, if anybody has any. So we do have some questions. I'll read them out. I'll keep the asker anonymous. Yeah. First question is: I had a sling placed after a hysterectomy 8 years ago. I don't have incontinence problems. Do I need to be worried about when it needs to be replaced? So that's a great question, one that's becoming more common. A little bit of background about slings. The first sling was placed in 1996. So we're just gathering 20-year data right now. The short answer is, if it's still working for you, there's no need to address it right now. It's kind of like your washer, dryer, or home TV. You're not going to just replace it because it's old. You're going to replace it because it's not working. So it may eventually fail over time, but when it starts to fail, and by fail, I mean you're having leakage that you are bothered by, that's when you address it.
We have another one. I'll skip to, I don't know if you want to do that one right now.
I've heard of blueberry juice.
Oh, I can read
okay.
Yeah. Okay.
I've heard blueberry juice helps prevent UTIs as well as cranberry juice. Certainly is possible. Again, I'm not sure the concentration of PACs in blueberries, but it certainly could work if there's evidence. Again, I don't poo-poo anything. Are there exercises that help if you have prolapse? So yes, there are a lot of exercises. There are a bunch of resources on the internet. There are podcasts. Vaginal weights help. Benoit balls. There's a ton that you can do at home to help with prolapse. So probably the best one is if you can buy vaginal weights online, and they have sequential sizes and weight levels, and you can put those in and try to hold them in the vagina for 30 minutes a day and gradually work your way up. Has a sling received any major setbacks? I'm not really sure setbacks. There's been some controversy about slings. Currently, a mesh sling is still the most common sling put in worldwide. If a patient has issues related to mesh, again, people can make slings out of your own tissue.
No.
Is it okay to take AZO as a preventive measure for getting UTI? So I'm not a huge fan of AZO. I think if you want to use something to prevent you from getting a UTI, you can use something called D-mannose, MANNOS. That's available over the counter. That's essentially a probiotic for the urinary system. And then the other one I mentioned it earlier, something called Ellura, ELLURA. That's a very high dose cranberry. Those are what I favor for prevention of UTI, not as much AZOs. I had the beginning of stress incontinence, and my husband has it as a result of surgery. What is the process of getting help? What should we ask when making for an appointment? So certainly for the female stress incontinence, you can make an appointment with myself. Any of the urologists are available and able to evaluate it. I typically am the only one here at Kelsey that will treat it. So you can just make an appointment with my office. For male incontinence, again, depends what type of surgery. If it's a result of prostate surgery, you probably want to see Dr. Hendon. He's the surgeon here at Kelsey that handles most of the male incontinence. One last question about AZO, which I know is very common. Is it okay to use AZO until you see a doctor for the pain? So yes, that is okay. I will qualify that statement by saying that some AZO can cloud or interfere with the urine culture, urinalysis results. So what I favor is I tell my patients, if you have an infection, call me. You don't need to come into the office. We'll send you to drop off a specimen. After you drop off the specimen, you can take AZO, whatever you want. We'll even sometimes prescribe antibiotics while we're waiting for the culture. But I like to get urine cultures in their purest sense before they're tainted by AZO or antibiotics.
All right, thanks everyone for attending the webinar. We just got some great information from Dr. Dillon, some great helpful tips, and understanding a little bit more about women's health. So we're appreciative of you being able to join us. It's on screen now, but if you haven't already, you can register for the next webinar, which is Wednesday, October 3rd, and it's on the topic of breast cancer. And we will be happy to see you next month. Thanks.